Well, good afternoon, all. Hopefully you're hearing me. Somebody could give me a thumbs up, maybe. I'm going to go ahead and continue with our spinal cord injury lecture series. Today I'm talking about wheelchair and seating specific to spinal cord injury. And again, if somebody could give me a thumbs up just to let me know that you're actually hearing me, that would be good. Okay, thank you. So that being the case, we're going to go through and my hope is that when you finish this presentation today, you'll be able to identify wheelchair seating goals for persons with spinal cord injury, and you will know how to justify elements of the wheelchair and seating prescription to accommodate for the person's diagnosis, comorbidities, environment, safety, and financial limitations. I'm going to talk you through different wheelchair components for both a manual wheelchair as well as a power wheelchair, and then talk through the different options for those. And then we're going to spend some time talking through the measurements specific for our PTs and OTs, but the physicians on the group ought to know this as well. Those components that are absolutely essential to wheelchair and seating prescription. And we'll finish off a little bit on the seating dynamics and how to make sure that we meet the seating goals as we go through. So what are the goals as we put together a prescription? Probably first and foremost is to provide independent locomotion for the community. We want our patients, our clients, to be able to participate in functional activities, and those don't just mean access at home, but also that they're able to access all of the things they need to do at work for leisure and for public transportation as well as their private transportation. A next very important piece of this is to make sure that we are providing appropriate positioning and stability. That's going to be for balance of their daily activities, to accommodate and prevent deformities, particularly musculoskeletal deformities, and to limit spasticity, as well as to maintain skin integrity. So a big part of what we're looking at, particularly with higher levels of injury, but as well those with paraplegia, how to provide appropriate pressure relief and pressure injury prophylaxis. Comfort and seating tolerance are going to be important pieces of this. And then how does it look, this piece of equipment that we're about to spend, in some cases, up to $55,000, $60,000 for. So let's back up a moment and just recognize that for different levels of spinal cord injury, we anticipate different outcomes. And so for particularly our cervical levels of injury, we would anticipate probably using a power wheelchair. But for thoracic levels of injury, paraplegia, most likely we would use manual wheelchair propulsion. However, these outcome metrics listed in the clinical practice guidelines don't really take into account aging. And I would say specifically aging more than a decade after the spinal cord injury. So we also need to take that into account. And as one of my last presentation was on aging, you'll recall that upper extremity overuse, particularly for those who are using upper extremities for wheelchair propulsion and pressure relief, major issues as a person ages. So we'll talk through a little bit of that as well. So a usual list of diagnoses and comorbidities for our people with spinal cord injury, particularly high levels of injury, may have all of these associated with them. Not all of our persons with spinal cord injury, but probably up to 10% will also have an amputated limb, either because of trauma at the time of injury or because of trauma afterwards and or significant pressure or wound issues in the lower extremities after the spinal cord injury. Typically, we've talked through these, but the ones that I want to pay attention to today are the ones that I have asterisk. So contractures are going to limit our seating and the systems that we'll be able to use. Those folks who have neurogenic hypotension, bradycardia, and or edema are going to need a special compensation for those to be able to get them, for example, into a Trendelenburg position. Those with mechanical ventilation or pacers may need to have additional components on their wheelchairs. Those obviously individuals who have had significant pressure injuries in the past and or are at high risk, we need to take that into account. Those with neuropathic and nociceptive pain, because that's going to also affect our positioning in the chair. Those with heterotopic ossification or osteoporosis or both. Those individuals with pelvic obliquity, scoliosis, and truncal instability are going to need special attention as well. Those with skeletal abnormalities, for example, we can talk about the scoliosis, kyphosis, those types of things, a girdle stone procedure. All of those are going to contribute to how we look at the seating system we put together. Whether the person's paralysis is spastic or flaccid, whether or not they have upper extremity overuse, and whether or not they have obesity that's contributing to their mobility issues. So when we, again, we're kind of taking that 30,000 foot perspective, we need to consider what environment the person is going to be using their wheelchair. So what is their environment at home? How are they accessing the home itself? How are they accessing the kitchen, the bathroom, etc.? If they're going to be at work, what does the work environment look like? What kind of obstacles will they need to overcome with their wheelchair and seating system? What are their goals with regard to leisure and then transportation out in the system? So all of these things need to be taken into consideration. Probably out of all of these, the most important thing is the patient goals. And we need to align those with the medical needs that they have as well. But at the end of the day, the person is going to be using this mobility device for at least 5 years moving forward. And we want it to make sure that they are going to be pleased with it, that it does all of the things that we need them to do, and that those access issues are meeting their goals. So what are access and egress issues? We can look at the ADA standards put forward in 1990 with regard to curb cut surfaces and terrain. While I would like to say every environment around us meets those standards, the reality is they don't. And so we have to recognize in a particular individual's neighborhood or at their work environment, they may or may not have full access as recommended by the ADA standards. Again, these are standards, these are guidelines, these are not mandates, and we have to keep that in mind as well. That said, if a person is using a ramp, ideally that ramp has a minimum 12 inches long for every 1 inch rise. And so, for example, if you have someone who is going to have to traverse a number of steps and you're trying to figure out how long to make the ramp to accommodate them, take this into account. Also keep into account that if they're going to have to turn at some point in order to accommodate the ramp in the space allotted, they need to have a minimum of 60 inches of turning space on that landing. Doorways should be a minimum of 32 inches. This is for the home, but also in the work environment. Hallway is a minimum of 48 inches wide. And again, housing standards are such that these are not always met, and there may be modifications that need to be done to accommodate a wheelchair. And remember, if you have a wheelchair, ideally the doorway is going to be 4 inches wider than the wheelchair itself, taking into account the wheels and whatnot as you go through there. So we have to keep that into account as we're looking at hip width, trunk width, etc. for the individual. The workspace, we need to make sure we understand height, width, and length requirements, making sure that we also provide space underneath the workspace to accommodate a wheelchair. And then ideally, the person has functional restrooms and kitchens. This may require modifications to allow access and egress with an elevated toilet seat, grab bars, flush levers, sink height, and door lever just to get in. Toilet paper access, no small thing. And then having low set or elevating countertops and mirrors, depending if we're talking about kitchens or restrooms. And then ideally a roll-in shower, although that's not always an option. For transportation, whether the person is doing this privately or otherwise, they need to be able to secure themselves as well as their wheelchair. A wheelchair that is not tied down is a missile. And so we need to make sure that we are keeping the individuals within the transport system safe. You send a 300-pound wheelchair after me that is not tied down because of a rapid stop, and I'm going to become injured. So we have to take into account how to secure those wheelchairs during transportation. So lots of things to consider. Financially, ideally, somebody with a spinal cord injury has an insurance or Medicare, Medicaid that will allow at least one wheelchair, and we'll have to make decisions if they have justification from the insurance company and or Medicare, Medicaid for only one wheelchair. What is going to be most important for that person for their overall quality of life. Now, we can provide justification in some cases, particularly for individuals who are working or going to school. Both CMS and private insurances will provide a little bit more leeway in those scenarios, but they will have to be medically justified. There are some advocacy services and private foundations that can help with the costs for a wheelchair. Nowadays, we can use GoFundMe. There may be private resources available to the individual, but recognize as well, it's not just the wheelchair itself, but it's also going to be the home modifications to accommodate the wheelchair, the work modifications to accommodate the wheelchair, and then the transport, whether that's private or public. So these are financial considerations that need to be discussed with the client as well as the clinical team that's working with them, so we understand the realities. A wheelchair prescription is going to need all of these individuals and all of these considerations as we move forward. So a wheelchair clinic may be a couple of different clinics. It's rare that you can do all of this in just one clinic visit. So having the patient, the family, or the client and the family there is going to be important. The physician is ultimately going to have to sign the script. The PT and or OT, and ideally these are folks who have assistive technology professional certification. All of these are going to be contributing to the prescriptions for the wheelchair and the seating system. The history we're going to talk through a little bit more in detail later, but is going to include the individual's age, time since injury, the level of the injury, and their completeness of injury. Their height and weight, as well as strength, range of motion, and truncal stability need to be taken into account, as well as additional medical conditions and risks that we talked about, as well as their remaining function. We need to know the environment that they're going to be in: home, work, transportation, leisure, and other types of opportunities to accommodate their lifestyle that is going to give them the best quality of life. We talked a little bit about the financial considerations. These need to continue to be discussed as we go through. There are a lot of things that we are going to have to justify. We recognize that in advance going in, although the patient usually doesn't. But we'll talk through more of this as we go through. So the stepwise process for the client is a face-to-face history and physical examination with the physician, as well as the therapists. And that includes a MAT evaluation. It includes trial and error in terms of the person's balance, truncal stability, and postural supports that may be needed. Doing a test drive, ideally in a system that they have not had to purchase yet, as well as a home assessment, and then putting together the prescription and documentation for the insurance company. My hope is that we do this all right the first time and there's not a delay. Oftentimes, and the reality is we just have to recognize it, insurances, Medicare, Medicaid, are looking for an excuse to not have to pay for this. And so there are times when they will send this back to you and tell you that you need additional justification, and that the claim is denied. And I've had this happen multiple times, but we shouldn't let that dissuade us from moving forward and trying to get the person what they truly need for modified independence. At the end, they have delivery of the chair and seating system with a final fitting with the therapists, and the assessment to make sure that they know how to use the wheelchair appropriately to keep them safe as well as others. So let's step away from the prescription for just a moment and talk about components of the manual wheelchair. Typically, you've got large wheels and an axle that connects those wheels with a seat and a back. You've got canes on each side of the back support and may or may not have push handles, arm pads and side panels, including the arm going down to the chair. And then you have the rigging, and the rigging may be detachable or not. It may be a rigid chair, it may be a folding chair. You've got at the wheels, you've got the tires, you've got the spokes, you've got the push rim associated with it. In the front, you have caster wheels. And then again, you've got your rigging, which includes your foot plate your foot plates and the leg rests as they go through here. So these are the typical components. Trust me, as we get to the power chair, there are even more components, but it's essential that you understand at least this so you can have the discussions with your clients as you move forward. So let's start to talk about some choices here. Rigid versus a folding frame. A rigid frame, basically the pros, there are fewer moving parts, and this is a lighter weight chair. This will provide a smoother ride with less vibration. Typically, this is monotube frame. And is easier to stow. The cons, you may have to remove the wheels to stow it, depending upon where you're going with it. And the rigid front end frame is not removable. So this may limit how close you can get to surfaces for transfers and that type of thing. The folding frame folds in the center, and also typically comes with removable leg rests for foot propulsion if the person has incomplete spinal cord injury. And or removable leg rests for doing stand pivot transfers. Again, those with incomplete spinal cord injury. The cons, the disadvantage of the folding frame is that there are more moving parts with a heavier weight and therefore less shock absorption as you're using these. So now I want to talk you through the standard, let's talk through manual wheelchairs first. I'm going to talk to you about the wheelchairs that you typically shouldn't prescribe. Let me say that again. Should not prescribe to persons with spinal cord injury. So a standard manual wheelchair, a K1, K0001, this is the Medicare standards or coding system, weighs more than 36 pounds without the front rigging. Okay, this is a beast to push around, and I challenge any of you to spend a day in one of these chairs and not feel tired and sore at the end of the day. It does have a weight capacity up to 250 pounds, and the size will typically accommodate most adults. The arm style typically is fixed or detachable. Foot plates and extension, the footrests may be fixed or swing away detachable as you go through this. Did I say you should never prescribe this for a person with spinal cord injury? It is not an appropriate chair. We'll come back to that. Standard height, again, for folks with a Brown-Séquard type of injury or an incomplete spinal cord injury, this may be a consideration, but I would say not. Again, this chair is going to weigh more than 36 pounds without the front rigging. and will have a weight capacity of up to 250 pounds. The difference between this one and the previous one is this is lower to the ground to allow foot propulsion as you're going through there. But again, typically not one I would prescribe for somebody with a spinal cord injury. You need to know what it is. This is a K2. Next up is what they call a lightweight manual wheelchair, a K3. This is not lightweight. I mean, it is compared to the standard. It's going to be less than 36 pounds, but typically these are still over 30 pounds. And this is without the front rigging. I put that in there just so you know. This is a little bit better than using a standard chair, but not much. And really, it shouldn't be prescribed for a person with spinal cord injury because of the upper extremity overuse associated with it. This is a high-strength, lightweight manual wheelchair for individuals who are over 250 pounds. So it does have a weight capacity up to 300 pounds. There will be insurance companies that tell you for your spinal cord injury patients, this is an appropriate chair. And I would say don't bow into their pressure because a person is only going to be able to use this so long, especially if their weight is close to 300 pounds. The upper extremity overuse associated with the chair and their body weight is huge. Now, ultimately, they talk about, and again, these are Medicare, Medicaid guidelines and guidelines that most insurance companies follow along. A high strength lightweight chair is covered when an injured worker, that's IW, so this is typically associated with workman's compensation, meets the criteria in 1 or 2 below. So in 1, the person is able to self-propel the wheelchair while engaging in frequent activities that cannot be performed in a standard or a lightweight wheelchair because of the person's body weight. And 2, the patient requires a seat width, depth, or height that cannot be accommodated in a standard lightweight or hemi wheelchair, and they have to spend at least 2 hours per day in the wheelchair. Again, most of the time, workman's comp won't start to push you in this direction because they know that, again, an individual of this size using over a long period of time, a lightweight wheelchair is ultimately going to have to transition to a full power chair and seating system down the road because of upper extremity overuse. So K1 through K4, they're available, but you shouldn't be prescribing them. Why not? So the Rehabilitation Engineering and Assistive Technology of North America group, RESNA, put together a position statement some time ago. This was actually updated in 2012 on the need for ultra lightweight manual wheelchairs. And they said that customizable manual wheelchairs should be as light as possible, durable for long-term continuous use, have customizable rear wheel and caster wheel location and configurations, have customizable seating configurations, and this is important, these are really ultra lightweight manual wheelchairs are the only acceptable option for individuals who rely on manual wheelchairs for independent manual mobility. Why is that? It's because of upper extremity overuse. We'll talk through this a little bit more. So an ultra lightweight manual wheelchair, some folks would say 30 pounds, but Rory Cooper back in 1996 actually wrote the book on this, but defined an ultra lightweight manual wheelchair as less than 25 pounds. There are several on the market, and this is without the front rigging, that weigh under 20 pounds. And mostly these are like the titanium and or titanium aluminum alloys. Now this weight is without the weight of the seat cushion, back support, and postural supports. So kind of keep that in mind as you're putting it together. And then they recommend, RESNA recommends keeping all of these things in mind. This is important because these are customizable to the individual to optimize the person's ability to get around the chair. I'm not going to talk you through these measurements yet, but recognize that they are absolutely essential to be able to make sure that we get the appropriate wheelchair to the person to be able to use long term. Now, just briefly talking about optimal positioning for wheelchair propulsion, and again, these are within the guidelines of RESNA as well as the Paralyzed Veterans of America upper extremity overuse guidelines. So B is the configuration that you should be shooting for. Okay, so this is the axle, this little circle in the middle of the square. And this represents where the axle should be sitting. You do want to have this as far forward as possible without losing stability. As you move the axle forward closer to the caster, you make the chair more tippy, but it also makes it more maneuverable. If you have somebody who doesn't have much truncal stability, you may have to go backwards a little bit more with the axle, but then that puts your shoulder in particular and elbow at higher risk for overuse injuries. So you're really looking for an angle here between 100 and 120 degrees at the center push rim. This is a situation where the axle is too high or the seat is too low. So this angle is too acute, and you're going to cause much more wear and tear at the shoulder, elbow, and wrist than you need to. In this situation, now you've got either the axle too low or the seat too high, and you don't have an acute enough angle. Now the angle is too great so that you don't get maximal efficiency as you come through here. So ultimately, what you want, if you're a manual wheelchair user, is an ultra lightweight chair with a moderate seat height and a raised and forward axle as much as possible. Your wheelchair propulsion mechanics make all the difference. And so you could get that nice chair, but if you're only doing your wheelchair propulsion here, then you're still putting yourself at high risk for upper extremity overuse. So what you want to teach our folks is to have long, smooth strokes that limit the high impact. If you start here, you got to push pretty hard to be able to move forward. So you actually, at this same point of contact, you're actually having to put in significantly more force than you are at the same point in this if you start back further with your stroke as you go through there. You want your hand to drift downward below the push rim when it's not in contact so that you have this semicircular pattern. This is going to reduce your overall stroke frequency, so the total number of hits on the push rim per day are going to be reduced. Your time for push to recovery is going to increase so that you have a longer push time. Overall contact is greater, and you're going to decrease the angular joint velocity here. So these are all things that you want to keep into in your mind as you're putting together the prescription for, oh, did I mention an ultra lightweight wheelchair? The other thing to consider, and I'll bring this in now, is what kind of wheels you're going to use and what kind of biomechanics do you need to have with regard to the push rims. So typically your drive wheels, that is your rear wheels on most chairs, Powers we'll talk about a little bit differently. So your drive wheels are comprised of your tires, and for manual wheelchairs, these are typically 24 inches diameter, and for power chairs, 18 inches. You've also got, as part of your wheel system, the rim and the hand rim on the manual wheelchairs. Your hub, which is the center of the wheel. Typically, you're going to have quick release axles, so you can remove these off of manual chairs, not so much off of your power chairs. And then you have your spokes, and your spokes connect the rim to the hub and provide stability to maintain that perfect circle on the wheel. These are either wire spokes, typically that'll be 24 or 36, either crossed or radial as they go through. And this is actually a lighter system than most of the mag wheels. The mag wheels are made of synthetic materials with less than 10 spokes. The nice thing is you don't have to worry about adjusting the spokes and whatnot. This is not unlike with a bicycle. So you have reduced maintenance, but these are a little bit heavier, and so you get that trade-off again. Casters have to do typically with the front wheels, and they range inside from 3 inches to 6 inches. Typically, the 3-inch caster is great if all you've got is smooth sailing. So this is nice if you've got nice smooth sidewalks and tile floors, and that's all you ever encounter, that's okay. The thing is with the sidewalk cracks, a lot of times these smaller casters will get stuck. So you have to consider that, depending upon the environment, you might want to go to a 4-inch or a 5-inch caster, so that you don't have quite the mobility, but you don't have to worry about getting stuck as well either. The other thing to keep in mind as you're looking at your wheels for your wheelchair is the camber. So the camber means that angle that you have further and further out, so that you have a narrower area from the top of the wheel to the top of the wheel on the other side, as opposed to the lower portion of the wheel, which is going to be wider wheel to wheel. So this is what we talk about camber. The more camber you have, the more stable you are laterally. However, along with that width, you may not be able to get through doorways and whatnot. So that may be a limitation for you. So the other thing to keep in mind is the alignment of the wheels. If you have toe in or toe out of the wheels at all, this is not unlike the wheels in your car, you're going to have increased rolling resistance, and you're going to have increased wear and tear on the wheels as well as the axles. And then the tires, you can choose from pneumatic, solid, or flat free. Pneumatic tires are like bicycle tires that you have to put air into to pump them up. This gives you a softer ride, but there's the potential that these will go flat. And if you're in an environment where you're likely to get a lot of flat tires, you might want to consider a solid wheel instead. This is going to give you a rougher ride and increased weight, but these are maintenance free. And then the other option is kind of the in-between, a little bit more expensive. These are the flat free, using a pneumatic tire, but filled with a semi-solid material. So these are options for the wheels, keeping in mind that you're trying to provide the best, smoothest ride possible, depending upon the person's environment, and still keep a light weight going for you. So what are the pros of an ultra lightweight wheelchair? Basically, they have a high strength to weight ratio. They provide high resistance to the metal fatigue and corrosion that goes along with using a wheelchair over time. They have longer use. What does that mean? These will last, 13.2 times longer than a standard wheelchair, or 4.8 times longer than a lightweight wheelchair. Okay, and this is based on materials that Rory Cooper has put together back in the mid-late 90s, and it still holds true. As well, the ultra lightweight wheelchair requires less energy to propel, 3.5 times less energy than a standard weight wheelchair, and 2.3 times less energy than a lightweight wheelchair. This is important as we're talking about long-term wheelchair use, somebody who's hitting that push rim 4,000 to 6,000 times, 4,000 to 6,000 times a day for mobility. The other thing is there are less costly repairs to this ultra lightweight wheelchair. Now, the cons, the initial expense is higher, and it may cost twice as much as a lightweight and 3 times as much as a standard wheelchair. However, the pros definitely outweigh the cons, and it's up to us, the clinicians, to advocate for our patients with spinal cord injury if they need a manual wheelchair to provide them the justification for an ultralight manual wheelchair. So this is a K5, K005. These typically come with a lifetime warranty, which means for a wheelchair user with spinal cord injury, about 5 years. But I know that that's what's said here. The weight, these are less than 25 pounds. Again, many of them less than 20 pounds. And then they can accommodate a number of different things, including different riggings, front riggings, as you go through there. You can have a rigid frame or a folding frame, again, keeping that in mind. Now, here's the justification. This is required. So the person self-propels the wheelchair while engaging in frequent activities that cannot be performed in a standard or lightweight wheelchair. And you may have to demonstrate this and defend this statement with actual video and whatnot from your physical therapist, occupational therapist during the evaluations. The other thing is that the client requires a seat depth width or height that can't be accommodated in a standard lightweight or hemi wheelchair. And the person spends at least 2 hours per day in the wheelchair. Now, again, this is written for injured workers, workers' compensation, but we use these same types of justification for persons with spinal cord injury. I'm going to scoot very quickly, how's my time, on these, the heavy-duty manual wheelchair. This is for folks who weigh above 250 but less than 300 pounds. This is still not an ultra lightweight, unfortunately. And so I try as much as possible to go to the ultra lightweight and modify as necessary to accommodate a person with a greater weight. The other option is the heavy duty manual wheelchair, the KO7, for those individuals 450 to 600 pounds. Again, you know, we're just going to have to make the case. If I've got somebody that large who is motivated, then I still want to go with an ultralight wheelchair. And actually, the titanium frames are going to last better than the frames on these. So the bottom line is the K5 for a person with spinal cord injury, the K5 ultra lightweight wheelchair is what we should be prescribing, period. And we can take that up on another time. Now, there's all kinds of other manual wheelchair bases. I'm not going to talk about these today because really these don't apply to our persons with spinal cord injury. So if you'll let me move on, I'm going to scoot on and talk about other options. So you have these push activated power assist manual wheelchairs. So the PAW, push activated power assist wheelchair. Indications, this is for those individuals who have been using an ultraweight manual wheelchair, ultra lightweight manual wheelchair, who are having upper extremity pain dysfunction. And so you have to diagnose that, include that in your justification, and you have to demonstrate that they have reduced pain using the push activated power assist wheelchair compared to the manual wheelchair propulsion. You also have to demonstrate increased independence with the push activated power assist wheelchair compared to the manual wheelchair propulsion. And notably, the individuals are going to be able to propel longer distances and over longer periods of time, notably increase in their ability to navigate barriers, ramps, curbs, etc. Now, those of you who maybe can't relate to this completely, let me just ask you, if you ride a bicycle, for example, you're an able-bodied individual and you got a 18, whatever it is, speed bicycle. And then you get older and you start having joint problems with your hips and knees. And now they have push activated power assists e-bikes. Oh, it makes all the difference trying to go up, for example, the causeway. Going up that incline is pretty tough for those of us a little heavier, a little older, with bad hips and knees, et cetera. And yet you give me an e-bike and I can get up there relatively easy. This is to put it into context, because this is what our long-term manual wheelchair users are encountering, just the wear and tear of the upper extremities for them. And so using these push activated power assist devices, so these are battery sustained, and there are several different options. So things to consider. Make sure that the person has the actual and compensatory vision. They can turn their head to see appropriately. Safety awareness and cognition and reaction time for faster wheelchair speeds. They should be able to propel the wheelchair with bilateral upper extremities. Their access and egress, their doorways are going to need to be about, well, they're going to increase, let me put it this way, the width of the chair and the wheels by about 1.5 inches for most of these systems. So make sure that they're going to be able to accommodate that at home and at work. They still need to be able to do independent pressure relief, or they're going to get pressure injuries. And so that's an issue to consider. And then some of these systems are better than others depending upon the person's body weight. And so the extender system will handle folks up to 265 pounds. If a person weighs more than that, but less than 286, they might be better off with the E-motion. So there are different brands, and I'm trying not to lean you one way or the other, just recognize that those are available. Push activated power assist manual wheelchair. This typically is going to go on to an ultra lightweight wheelchair to again, minimize the wear and tear in the upper extremity for folks. So what about powered mobility then? I'm gonna go ahead and extend into those individuals who are using only powered mobility. Why would that be necessary? Well, they are unable to propel manually and or do pressure relief appropriately, and primarily that's because of lack of strength for the elbow extensors and shoulder stability. So individuals who have injuries between C2 and C4 basically aren't going to be using power, aren't going to be able to use manual wheelchairs anyway. There are some folks who can propel a manual wheelchair if it has pegs on the push rims. They're going to need additional devices on there, some with C6, C7. Typically C7 is usually that point where folks are going to be more likely to be able to propel a manual wheelchair, at least for some time. But these are for the very lightweight individuals. And a person gains weight, there's going to be a lot more wear and tear on their shoulders until they get to C8, T1 intact. They don't have full shoulder stability because of the compromise, particularly with the pecs and latissimus, as we talk through those different things. So recognize that first and foremost, for persons with high para and cervical levels of injury typically are going to need a power wheelchair for mobility. So who qualifies? Those who cannot meet the needs using a manual or power assist wheelchair. So this is going to depend upon level and completeness of spinal cord injury as well as the comorbidities. So take into account shoulder pathology, obesity, body weight, COPD, CAD. Those are going to be contributing factors to the need for power mobility. Folks need to have good vision, actual and compensatory, good safety awareness and cognition, recognizing this can worsen with age. Their reaction time may also decrease. And the controlling part for the wheelchair, it needs to be sufficient to manage the wheelchair at all times. So whether they're using their hand, their foot, or their head as a controller, they need to be able to stay in contact with that controller at all times so that they don't lose control of the wheelchair, run themselves off a bridge or into a wall or into other pedestrians, for example. And then they need to have appropriate transportation options. These chairs can weigh up to 350 pounds without the individual in them. So keep that in mind as well. So the advantages and disadvantages of powered mobility. Powered mobility reduces the propulsion-related repetitive strain in the upper extremities. It allows the person to conserve their energy and reduce their overall body fatigue, increases their speed of mobility and the ease of traversing uneven terrain and inclines. However, using powered mobility is going to reduce their transportability. They're going to need a custom van or lift or ramp to be able to get in. And again, these chairs can weigh up to 350 pounds without the client. Power wheelchairs require more maintenance, and the individual is going to gain weight because their energy expenditure, daily energy expenditure, is going to be reduced. Physical activity is going to be reduced. And therefore their fitness may be reduced as well, putting them at higher risk of injuries with transfers and risk of cardiometabolic disease. If you don't know what that means, maybe look back at some of my other lectures. So a person we've determined needs a power wheelchair. Where do we put the drive wheel? This is the wheel that is actually propelling the person in the chair through the system. We can use the older, the original drive type, the rear wheel drive. This is the most stable system. You've got the power wheel now at the rear and of the power base. These chairs are the ones with the highest speed, but they also have a large turning radius. They're not as mobile. And for persons who have been using a manual wheelchair, intuitively, it makes more sense to be able to drive these than the mid-wheel or the front-wheel drive. So let's talk about the front-wheel drive for a moment. The front-wheel drive chairs, you've got your drive wheel up in front at the front of the power base. These are great for those individuals who have a lot of uneven terrain going up and down hills. Overall, the speed is lower because you have a lot of fishtail at higher speeds. The rear end is harder to control, and you're more likely to fishtail and or tip the chair. So keep that in mind. Generally speaking, we set the speeds limit lower for a front wheel drive than we do for a rear wheel drive chair. And then the mid-wheel drive chairs, and a lot of folks prefer this. This is where the power wheel is in the center, and you've got casters front and back. You've got high maneuverability in small spaces, but this is not ideal for those individuals who have uneven or steep terrain because you get stuck on either the front or the rear wheel casters as you go through here. I want to talk a little bit about power seat. How am I doing on time? So the seat to back angle in a tilt, a power tilt system, remains constant. So this angle doesn't change, whether you're going anteriorly or posterior. This seat to back angle remains the same. The anterior tilt allows for tone management and can improve functional reach and reduce upper extremity overhead reaching. The posterior tilt, typically we use this for pressure relief. You've got to go at least 45 degrees in order to get appropriate pressure relief. This can also help with neurogenic hypotension. It can help with spasticity at times. The nice thing about the tilt system only is the person never loses contact with their controller. And so there are circumstances, if you're only using a recline, for example, you may lose contact with your joystick, or I should say your controller device. These are really essential for pressure relief. They used to just have recline only, and the problem with this was shear. But the power recline open and closes the back angle, as we were talking about before, but you do have to be aware of shear. It can provide postural stability with those with trunk weakness, so you can take them back a little bit more and they don't have to worry about falling forwards. The full recline with elevating leg rests, we'll talk about on the next slide, can help with toileting and peri-care, the perineal space in a wheelchair. Also reduces the need for transfers during the day. Combined with tilts, this can provide additional pressure relief. And then, as I said, you've got the elevating leg rests. These can be elevating and articulating. And so this is going to help you to flex or extend the knee, optimizes the pressure distribution during the tilt and recline, so that you also have some pressure relief from the leg rest itself. It can also help with the pelvic positioning and pain management, as well as obviously elevating the lower extremities can reduce lower extremity edema. The power seat, this whole seat raises up and down. This changes the seat to floor height without altering the angular orientation of the seating system, allows you to reach higher surfaces for mobility-related ADLs, can improve safety and independence with transfers, and allows eye contact with some individuals while reducing cervical strain. And this is not a full stand, although those are options as well. Interest of time, I'm going to move forward and talk a little bit about the control devices. Generally speaking, you've got two kinds of controllers. You've got proportional drive control. So the speed and direction is relative to the joystick deflection. So the further you take this back or the further that you move it forward, the greater change in speed and or direction as you go there. This requires range of motion and strength to activate. Some individuals don't have sufficient finger flexors and hand intrinsics, and so they may use a goalpost configuration that you rest the person's hand in instead of having this type of a toggle. Other individuals may need head array type of system using fiber optic beams to activate. They may need a sip and puff pneumatic system to be able to activate the controller. So this is the pneumatic type of controller device. And then the electronic requires no force, essentially. So you've got a number of different options, and our therapists are great at knowing, depending upon the person's level of injury and completeness of injury, they will help us to trial different systems. We want to find the system that is going to be the most consistently utilized by the person safely as we go through there. So just briefly running through the power chairs, you've got the K10s. So this is just your standard weight frame motorized power wheelchair. And then you've got programmable, and this is going to be more appropriate for most of our folks with spinal cord injury because you can change the speed, the tremor or vibration, the acceleration control, and the braking systems as we go through there. So this is a K11. The K12 is a lightweight portable. What? Yes, you can actually fold these up. They can be as little as 53 pounds. You remove the batteries, and so obviously it requires an assistant. But this is an option for some individuals just because of their environment and their lifestyle choices. More typically, we're going to be providing customized motorized power wheelchair bases. These are the K13s, and this is what you'll see, particularly for our folks with tetraplegia. Our therapists are going to be utilizing the K13 base most of the time because of the customizability. And then for some individuals, you're going to have a K14 base. This, for example, can accommodate all terrain types of scenarios. You got folks that are out hunting, et cetera, in these kinds of chairs. So I know that I'm running a little bit late. The medical evaluation for the physicians. Review of systems, especially you want to note any changes in body weight. Typically, this is going to be increase in body weight. You want to know if the individual is having neurogenic hypotension, edema, or require ventilator support. And then you want to report out, this is a review of systems, any problems that they are experiencing with regard to joint pain, truncal stability, range of motion, or changes in their functional level. Skin, obviously, is something that you want to ask about. Have they had previous, or do they currently have a pressure injury? And then the physical exam is an extension of the review of systems. You need to identify these things, note any musculoskeletal limitations or deformities, and especially report on any skin issues related to the back, sacrum, ischium, heels, and ankles, and also note the chair and seating system. The therapists are going to be using your review of systems and physical examination to move forward with the following. They're going to be reporting out and assessing on a mat the person's symptoms and causes, for example, with regard to reflexes and spasticity, tone and contractures. They want to know the conformation of the pelvis. Is it neutral? Do they have problems that they're going to have to adjust? Is it fixed? Do they have good range of motion at hips, knees, and ankles? And then their sitting examination is going to include all of these things as we go through there, because they're also going to want to report out and to provide options to reduce the influence of tone and reflexes to make sure that they are supporting appropriate stability in the chair. So again, running a little bit short on time. This is essentially the Bible, if you will, put together by Waugh back in 2013 out of Colorado. Most folks are still using this system, and I'll just say that it's several hundred pages, but I have it available. If you're interested, I'd be happy to share this with you. It talks about the axis system so that we can speak appropriately about the different components of the chair. It includes the different measurement landmarks that are going to be necessary for our therapists to get the right chair measurements, because they're going to be taking the anatomical landmarks, using those to assign lengths and widths for the different components of the chair in the X, Y, and Z planes. So making sure that they are doing all of the measurements. There's a lot that goes into this, and I don't have time to go into it in detail. But our therapy evaluation is so important to get the appropriate seating system now that we found the appropriate wheelchair. Again, this is the Bible of wheelchair measurements and seating systems. It talks about all of the essential measures, and these are listed out here. Again, I'm happy to provide my slide set to anybody that would like it. The key thing here, if there's one thing that I would say with regard to our physician therapy interactions, we always want to measure twice so that you only have to order once. It's really frustrating to everybody involved, but especially the client, if they get the chair and there are components that were not measured appropriately. It's too short, too long, etc. These are, again, translating those anatomic measurements to wheelchair surface for the backrest, the height, width, and depth, the contour, the headrest height, armrest height and length, the hand pads, the seat depth and width, and leg and foot rests. All of these are going to be important measurements to make sure that we get the person seated appropriately. Obviously, lots of other things that are taken into account, and our therapists are doing great jobs to measure and give us the most appropriate seating system. And what does that include? We want to make sure that we are positioning the person for function and pain relief and for pressure injury prophylaxis. We also want to make sure that we're providing appropriate support for the spine, pelvis, hips, and thighs to reduce pressure, to reduce pain, and to optimize function. Number of different seating cushions available, foam cushions, generally not appropriate for our persons with spinal cord injury because they don't give enough pressure relief. Typically, we're going to use either the gel fluid-filled cushions, which provide contour and pressure relief as well as stability, but these can freeze in cold environments. Not a problem maybe here in Miami, but if folks are up north in the cold weather, could be a factor. And then the air cell cushions. Low profile provides better stability, but still not the stability that you get out of the gel and fluid-filled cushions. You don't get as much pressure relief with the low profile as you do the high profile, but the high profile reduces stability within the seating system. You can have the multi-quadrant cushions so that you can quarter this out depending upon what you need for pressure relief and stability. The problem with these is they can deflate and overinflate as you change barometric pressure. So if you're driving up in the mountains, if you're going from Denver to San Diego or vice versa, you're going to have to accommodate by either adding or taking out air in this cushion, or the person is going to be at risk again. And then making sure that we provide the appropriate backrests. The standard comes with a fabric, typically lightweight. This stretches over time. You can get the tension adjustable backrest, which provides better comfort and moderate support, but doesn't have quite the durability. And then the solid contour for trunk control and postural support. This adds weight, but can be essential to maintain appropriate posture for some of our clients. And then ultimately, you want to map out what are the pressure points, what areas do I need to be worried about. So this can help us to determine the causes of pressure injuries and to determine optimal support and cushion. We can use the mapping system to provide biofeedback to the client so that they can check their strategies. Maybe they need to lean forward longer. Maybe they need to do lateral bending to a greater extent. And it tells us if they're able to do sufficient pressure relief, for example, with depression pressure relief. Ultimately, this is going to help our folks recognize when they're at risk. And so we're going to train them on that. I know I've just about taken up all of our time. I have our references there, but have just a couple of minutes for questions if anybody has questions. I know most of you, this is not the first time you've been exposed to wheelchair and seating systems, but maybe it is the first time that you've heard the whole spiel just specific to spinal cord injury. So open for questions or comments, or everybody's fallen asleep. which I can understand. It was a long lecture. All right, I'm not going to pressure you fuller for this. Let's talk about getting together again sometime in the next couple of weeks. I hope everybody has a great day. If you do have questions or you'd like a copy of the slides, let me know. Happy to pass those on to you. Have a great day.